And welcome to a webinar called The Perfect Fit, Tailoring Hemophilia A Management to Each Unique Patient. Special welcome to those in British Columbia, Alberta, Saskatchewan. This webinar is designed for you, but there may be people from elsewhere in the country, and you're welcome as well. I think on the screen you can see our presenters, and I'll be introducing them to you in a second. My name is David Page. I'm National Director of Health Policy with the Canadian Hemophilia Society, and I'll be your moderator for this evening. I think on your screen you can see icebreaker polls. There are a couple of questions here. There's one question that you can see. You can scroll down to the next question. So while we're waiting for people to join, I invite you to go ahead and respond to these questions. And I'll be back in a minute to get things going. All right, so let's move on with the help of our guide, Rebecca from Medicom, who's responsible for the logistics and organization of this meeting. And also thanks to Takeda, who is our supporting sponsor for the event. I think I'll ask Rebecca to give us some of the housekeeping details.
Excellent. So welcome everyone, and thank you, David Page, for that lovely intro. Before we get started with the content for tonight's webinar, we just wanted to point out a couple functionality items for you with this Zoom webinar. And so first up, as David mentioned, there should be a little pop-up window on your screen with a couple survey questions. We're seeing some responses trickle in now, but if you haven't already, please feel free to answer those 2 icebreaker questions. So you do need to answer both questions, scroll down to the very bottom of that window and hit submit, and then we'll see your results come through. And we'll share those before we get too far into tonight's presentation. Next up, there is the option to submit any questions you have throughout tonight's webinar via the Q&A or the question and answer function. And so you'll find that button at the bottom of your Zoom window. And if you click on it, it'll bring out a little pop-up window again where you can submit your questions. Of note, you can submit them anonymously. So feel free to do so as you're comfortable. And then the other piece that's really interesting is if you see some questions come through from other attendees that you are also interested in hearing the response to, you can also upvote the questions that are submitted. And all that does is brings those questions higher on the priority list to make sure that we get to them before the end of today's webinar. So without further ado, passing back to you, David Page.
Thanks, Rebecca. So this really is a joint effort of the CHS and its chapters in BC, Alberta, and Saskatchewan, with support from Takeda and support from our logistic people at Medicom. Just to say that all the content has been developed by the speakers, not influenced by the sponsor. And we're asking that people not ask questions related to particular brands of products. Particular factor 8, types of factor 8, for example. We'll be talking more about classes of products, so standard half-life, and other classes of therapies. Let's see if we can we get the slide with the speakers, please. So it's a really great program tonight on a very important topic, which is personalization of care. We have 3 speakers: Dr. Mark BELLETRUTTI, who's a pediatrician at the Dr. John Akabutu Comprehensive Care Center in Edmonton at Stollery Children's Hospital. HILARY HAMILTON, who is the nurse coordinator at the Adult Center in Edmonton, Alberta. And Cleveland Pagani, who is a person with hemophilia and someone I know well because he works with me on our National Blood Safety and Supply Committee. Each of these presenters will be making a short presentation. Dr. BELLETRUTTI has about 30 minutes, HILARY HAMILTON 20 minutes, and Cleveland about 10 minutes. After each session, we'll be stopping for questions. So please get your questions into the question box as we go. And then we'll also have a 20-minute question and answer period at the end for more questions that we haven't already covered. And these are the learning objectives. I think this is a really important topic. You know, in the past there was really sort of one kind of product and one kind of approach to care, but in the last few years this has really changed, and so care is being personalized, and so that's the topic for tonight. So without any further introduction, I'd really like to welcome Dr. Mark BELLETRUTTI for his presentation.
Okay, thank you. The house phone is ringing, so we'll wait for that to stop before almost as good as kids wandering into the room. Thanks everyone for joining us tonight, and excited to give you my take on personalization, and maybe plant a few examples of patient scenarios that I've put at the end of my talk to get us thinking about how do we organize personalization? How do we present it to you, our patients, or our parents of our patients, and really answer your questions, as well as explain to you why we think it's worth having a conversation when we see you in clinic. Let me just scroll through here. There we go. So just to take everybody back to the beginning. So as many of us know, normal levels of factor VIII are in what we call the 50 to 150% range. And in general, there's no bleeding concerns in that range. Persons with mild hemophilia, whether that's A or B, tend to run factor levels between 5 and 40%, which is quite a wide range. And you can imagine that people who maybe are on the lower end of that spectrum may have higher potential for bleeding versus those at the higher end of that range. Although in general, bleeds are not very common in this group, and generally are associated with major trauma, major injuries, or surgery. Our moderate patients will have factor levels that are above 1% and below 5%. And really, this is a variable group. Some of these patients have occasional to very frequent spontaneous bleeding and almost behave similarly to patients with severe hemophilia. And then other patients, regardless of where their factor level falls in that range, behave more like our mild patients, where they have very few bleeds, and they tend to be associated more with trauma, surgery, or injuries. And then our severe group are those who have less than 1% measurable factor VIII. And these are really the persons who have issues with spontaneous bleeding, whether that's in joints or muscles, or significant bleeds with seemingly minor injuries. And really a group that we've seen benefit the most from prophylactic therapy, where we really is the crux of our personalization talk tonight. And certainly these levels apply for patients with persons with hemophilia B as well. These levels are the same in that group. So we know that your factor level does confer a measure of bleeding risk. And as I mentioned with the moderate group, shown here between sort of 1 and 5%, you can still have significant bleeding even if you're in the moderate group. And then the chance of that happening tends to fall as you get higher and higher. And looking at it a slightly different way, this shows on the horizontal axis how much time you have in a week with where your factor level sits, which is the vertical axis. So you can see here that you're going to tend to have more bleeds if you have if you have more time below a certain level of factor, and the longer time you're below that level, you have more bleeding. So really, the importance of this slide, rather than presenting confusing graphs to everybody, is that where the lower end of our factor levels after we've treated and before we give our next treatment really is something that we need to focus on and try and use to our advantage and figure out what level works for you, the person sitting in front of us in clinic, and not a group in general, and see where do you need to be, or what's sort of the lowest level that we think we can get to before we start running into trouble with bleeds. Or do we pick a level as a starting point, say 2% or 3%, and we try and keep you above that and sort of design a treatment plan to allow you to stay above that level, you know, almost all the time or all the time, depending on many different factors, and see if we can really have no bleeding. That would be the ideal objective in this case. So, as I said, a really aspirational goal for hemophilia is 0 bleeds. No one should be bleeding, and we have treatment that we think can help achieve that, because we know even 1 bleed can be life-threatening or cause permanent damage. We know that, you know, I look after very young children where the risk of intracranial hemorrhage is quite high, and that can be a very devastating consequence. And that only has to happen once, and it can have lifelong complications associated with it. And even, you know, repeated bleeds in a same joint leads to joint breakdown, leads to joint pain, leads to limited mobility, and affects quality of life, and really, you know, is something we want to try and minimize as best we can. So, keeping with that goal of minimizing the amount of bleeds we have, we also have to take into account where do we want the factor level to be, and that really depends on where the person sitting in front of us in clinic having this discussion, what are their goals? You know, do we need to have everyone up at the normal levels all the time? Sometimes we do need it up there, or can we tailor it depending on the lifestyle, and even can we tailor it within the same calendar year depending on lifestyle? You know, some patients, their lifestyle is a bit more sedentary. They're doing activities that aren't on the highly active, high potential for injury scale. But there are other patients who have different interests and maybe enjoy things like skateboarding, or, I mean, simple things. I look after children, and all our children love to ride bikes. Some of them are a little more cautious than others, but really we have to think about where do we want these factor levels to allow them to do those activities without the anxiety or fear in them or their parents of having major injury. And then certainly you want higher levels if you're having surgery, either during surgery where you probably want them normal, or after surgery while you recover, you probably want to run your levels at a high enough level to allow good healing. And so this can be a continuum, and this can change over a person's lifespan. You know, patients can be quite active in their younger years, and then depending on the type of occupation that they get into, they may have less activity, or they may have periods of a high activity on the weekends when they're not working, and less activity during the week. And so that's things that we can take into account when personalizing a treatment plan for the people we look after with hemophilia. So really, personalization is taking what we know about an individual's factor VIII levels at different time points after we give them a dose of factor VIII. And this is what we know as the PK profile, or the pharmacokinetic profile. So pharmacokinetics, really the definition of that word is how the drug, or in this case factor, behaves over time in the person that's received it. And so this can be quite variable. You know, we can have patients who all give the same dose of factor, and some of them, as soon as they give it, will get up to 50, 60%. A large group will get around the normal if we're giving them a dose that corrects it to normal of around 100. But then we have people who go much higher than that. And that's really just owing to the individual differences. While the large majority will follow along a very standard curve, there are going to be people who take longer for that factor to disappear, and as such may have factor levels that are still above what their usual level is if they had no factor for a much longer time, compared to other patients who may get down to 0 at the 36-hour mark, There's going to be other people who can go 48 hours or longer and still have reasonable factor levels that can protect them in most activities. And so really doing this on an individual basis for each of our patients allows us to really look and see where do they fall? Are they in this large group in the middle who follow a fairly normal and predictable pattern? Or are they someone who really breaks down their factor quite quickly and may need more frequent dosing? Or are they someone who is slower to break down their factor and they still have good levels even 48 hours out or longer? And this obviously depends sometimes on the type of factor you get. For example, standard half-life products tend, you tend to need more treatment to keep your levels higher than your baseline, compared to an extended half-life product where patients may be going into 3 days after receiving their extended half-life factor product, in the case of a factor 8, and they may still have good, measurable, and safe levels at that point. And so they may be able to give their treatments less frequently. But giving them, testing that and doing what we call a PK profile on these people can really help us and give us a lot of valuable information. And really it becomes one tool in our toolbox to help design a treatment plan that really fits you, the patient who's sitting in front of us, rather than, what we used to do was, oh, well, you have hemophilia A. The recommendation is standard half-life factor 8 3 times a week, and that'll protect you. Or you have hemophilia B, you need to treat twice a week with a standard factor 9 product. And that's just what we do for everybody. We know that everybody is not the same. There are differences, and we can use those to help design the best treatment plan that works for each of our patients. So we want to get away from the one-size-fits-all approach because we know for a lot of patients that'll be fine. But there are other patients who, every one of us is unique. We have our own unique interests. We all like different sports. We all suddenly find out that we're talented at different sports than our peers, and we cultivate our interests over time through childhood, depending on what our parents allow us to do. And then as we get older, we make friend groups and we get into different activities. And so really we want to be able to personalize, and this could change over the lifespan of a patient, to allow them to accommodate what they want to accomplish in their life, whether that's lifestyle, sports, work, and really make it something that we can allow them to do without a high anxiety of having lots of bleeding and potentially limiting their ability to do those activities. So it's a multifaceted approach. I talked a bit about the PK profile, which is really just one part of the circle here. It depends with age and weight. That'll help determine how much factor and how often. Obviously, we're going to have to, when I take care of small children where it's sometimes difficult to do IV access to give factor, we need to take that into account, that we have to balance too much treatment and the difficulties with IV access with giving the right treatment to protect them. Your genetics, which inform how you respond to factor, play a role. How often are you bleeding? We have to take that into account. Maybe a higher level before we give the next treatment is the way to go there. What are your joints like? Are there joints that are a problem and tend to bleed more than others? And so again, that can help inform how low of a level do we let you go to before we recommend the next treatment. How adherent are you? Or how adherent do you want to be? For some people, the ideal personalized treatment is a moderate dose of factor every day, but not everyone's going to be able to do factor every day. That's unrealistic to a lot of people. And so we have to take that into account and really work with you to find out what's going to work best for you. Physical activity and lifestyle. Someone who works 5 days a week sitting at a desk for 8 to 9 hours is going to be different than someone who's working a very manual job where they're moving most of the day, lifting heavy things or doing work with their hands, or have a very mobile job. That's going to be a very different approach. And then really, what are your goals? what do you want to get out of this? Are you going for 0 bleeds? Are you going for less bleeds than the year before? How do we move in that direction, and what's going to work best for you? And so we have to take all these into account and really have a discussion, or sometimes series of discussions, to decide what's going to be the best for you at this point, and or what do we try and we modify as we go along, and really personalize it to allow you to do what your goals are. So I said goals are individual, and it could be as simple as being protected while playing sports, not missing work or school because of bleeding, being able to do your work safely, being able to spend time with your loved ones doing active things after work, whether you're playing golf once a week or going for walks when it's nice outside. You want to still have those goals of less bleeding, but you want to infuse less per week. So maybe we have to look at different products than you're on. Some of my kids want to join high school teams when they get to high school. And so how do we design an approach to allow them to do that? Maybe you're very handy. You want to work around the house and you want to do it safely. Or you want to really enjoy your weekends and not be limited by the potential for bleeding. And how do we design treatment to allow you to achieve those things? So really, I'm only one part of the team, and all of us in the comprehensive care team, and most of our centers have many, if not all, of these people contributing to help us do this. I mean, our physiotherapists are invaluable in helping us figure out a good activity regimen and how best we want to protect that, and help us think through what we need to do that safely. Our social workers are invaluable, as is our nursing staff, and then all those people behind the scenes who help us ensure that we have the right products and get them available to you. And then our learners who eventually will take over for us when we stop doing this job, to again carry on and understand these individualized approaches that we're trying to achieve with our patients in this day and age. So just a couple scenarios to think about as we close, and could be reasonable for discussion. So this is, picture this patient. He's 15 years old, severe hemophilia A. He's on a standard half-life factor VIII product. 3 times a week is his prophylaxis, fairly typical of what we've done for many years. It's working reasonably well. He hasn't had too much breakthrough bleeding over the previous years. He's good at following his 3 times a week regimen during school. But summertime is different. He doesn't have that routine. So he forgets more often because his schedule is all upside down, and maybe does twice a week if we're lucky. And that depends if his mom is on his case or not. And so he's less adherent in the summer, which is pretty typical, a lot of us when we're off school, but seems to do better with more of a routine during school. So he loves basketball. He's a basketball player. He does it recreationally. He plays a lot with his friends at school. And during the summer, he's outside on the court because this is the sport. And I mean, he's 15 in Alberta. That's the start of high school. And so he wants to try out for the high school team. And so he's come to see me and he wants to know, how can I do this safely? I don't want to get injured because the high school basketball seasons are pretty short. They're not existent right now in COVID, but let's imagine this is pre-COVID or post-COVID where we do have high school sports again. And so, if he has a bleed in his knee or his ankle, and he misses a week and a half of games, then that's most of the season in a lot of high school basketball seasons. So really his goal is to not bleed while he's playing, assuming he makes the team, which he's hoping to do, and really wants to have a good tryout, do that safely. His goal is to make the team, be an active contributor, and play the whole season without injury. So really this personalization discussion, ideally it'd be great to have a PK if we haven't done it yet, because that'll help us decide how often we should be treating. And then we have to think about, when are his games? When are his practices? How active is he going to be during the week? Are there days where he won't be doing any activity? Can those be days where we can tolerate a lower level? The basketball season is short. Is there other sports he's interested in? Or can we be really aggressive and do lots of treatment during the basketball season, knowing that the goal is to keep him healthy throughout that? And then we can back down to, a more less intensive regimen where we're not infusing as frequently on the off season. But I mean, like any student athletes, there's always off-season training. And so really we have to consider all those. I would have my physiotherapist in here as part of this discussion, along with him and his parents. We would probably liaise with his coach to get a better idea as to the schedule and the activity that they're doing, with his permission, of course, the patient's permission. And we would see what we can come up with that'll be acceptable to him, that he will be able to do, and that will allow him to really realize this and cultivate this interest that he has. So that's just one scenario to think about. Certainly this could go any different ways, but just some fruit for discussion as we go on with the talk. The second one is a patient just a bit out of my age range, because I graduate them when they're 18 to the adult clinic, but fairly reasonable phase of life where there is transition and a good opportunity to discuss treatment. So this is a 22-year-old male, again, with severe hemophilia A. He was on 3 times a week prophylaxis all through childhood and adolescence, and was reasonably adherent with that. He decided to stop prophylaxis and went to on-demand during his transition out of high school, as he was doing post-secondary work and really sitting in class all day and didn't feel he needed to be as aggressive with his prophylaxis. And that was his decision at that time. He really didn't have a lot of bleeding during childhood. As I said, probably part of reason that he was reasonably adherent, so he doesn't have any target joints. He did remember to treat himself during his post-secondary training when he was doing practicum work for the type of program he was in. When he was out in the field and being more active, he did remember that would be a treatment day, and made sure that happened. So he's done his diploma. He's going to be a land surveyor, and he just got a new job as that. And it's a fairly active job. He's not sitting at a desk all day. He's out in the field. They're doing all the survey work. Sometimes the terrain is not stable. It's not a nice sidewalk all the time. It's uneven terrain. There could be instability issues. So he's concerned about that. And he's asking in the clinic about the best way to stay protected, because this is his first job. He wants to make a good impression at the beginning. He doesn't want to miss work frequently due to injury, because he feels that will severely compromise his ability to continue working in this area, and it is something he has high interest in. So again, this could be a work situation where we need to design something and maybe relook at a prophylaxis regimen that will work best for him, keep him as protected as possible during the days when he's out in the field. We'd have to understand, what does he do on the weekend? Is that a time where maybe we can pause for a few days with treatment, or does he have other activities that he does there? So again, just things to think about. This type of personalization happens all through the ages with different patient scenarios, and really we have to take into account all these factors to make the best decision for the patient. He would benefit from a PK. I mean, even if he had it in childhood, your ability to break down factor can change as you get older. And so doing a repeat test now that he's officially an adult would be a reasonable thing to do, to again try and give him the best plan to allow him to do good work that he's really excited to be doing. So those are scenarios, again, just for people to think about. There really isn't a right or wrong way about this. That's all I have at this point. I'm happy to take questions. I know Hilary is going to be talking a bit more about some of the PK tools that we can use, as well as some other scenarios. So there will be more discussion about this as we go along, but happy to take questions at this juncture.
Thanks for that great presentation, Dr. BELLETRUTTI. One question that's come up is, I'm not sure if it's from a parent or a person with hemophilia, but they're asking, how do they go about bringing up the question, with their physician or with their nurse when they want a more personalized approach to their care?
I mean, I think it can come up in many different ways. I mean, what I've seen is people really asking about, I'm really interested in this activity. How can I do it safely? And that can really be, the beginning of the conversation of, okay, we're going to talk about safely doing this activity. I mean, it could be as simple as, please wear a helmet every time you get on a bicycle, which for some of my pediatric patients is still a challenge. But that could be the start. If it's an organized activity, I'd want to know how often are you doing it? And so that really can be the start of how do we want to use this type of personalized approach to allow for better treatment. And it may be that it's as simple as, let's do the PK. Maybe your 3 times a week or twice a week regimen is just fine at this stage. Or maybe it's an opportunity for us to say, well, let's look at how we're treating you, and maybe we can do this differently. So it's really asking the question, how this seems to be working, but I want to look at a different treatment. And so how do I do that? I think is a reasonable way to start the conversation.
The next question is, when should I be getting a PK test?
It can be really any time, and we've advanced in ways that we can actually make it fairly simple. I mean, there's a traditional PK which used to be the old way to do it, where you had to come in and really you spent all day getting blood tests, every 1 to 2 hours, and then you came back the next day for a 24-hour level and so on. We don't do it that way anymore. We can get a reasonable estimate of how you handle factor, really with potentially 3 blood tests. I would do a factor level before I give you a dose of factor, because I know when you gave the factor before. So maybe that's a 48 or 72-hour level. And then I can do another level sort of 1 to 3 hours after you give factor, which could be when you come to clinic. You show up to clinic, we do your first blood test, we give you your factor, you have your clinic appointment, which in most places you're there for, the whole morning, if it's a morning clinic. And then we do another level before you leave. And that's, about a 3-hour level. And then maybe we do a level first thing the next morning, and we have a 24-hour level. And that could be a reasonable estimate of how we do it. And so it can be quite simple. It doesn't have to be a lot of blood work, but it does take a little bit of commitment and knowing that. So, and really that can happen at any age. I'm a bit challenged because a lot of my kids, it's really hard to get blood off them because of their size. And so that can be a challenge at some time. So I tend to reserve it for the more older kids who are potentially more in organized activities, because that's when I'd want to have a better idea. But I do them in very young children in very specific situations if needed. But really, if you're interested in your PK level, it's as simple as asking the clinic and saying, when can we make this happen?
But in your scenarios, you talked, clearly you were doing a lot of, I guess, discussion and negotiation with your patient. What are their goals? How you can help them meet those goals? Have you noticed whether that results in better adherence with what you agree upon? Because adherence is always an issue.
I think so. I mean, this is a fairly new approach for most of us. And so, I mean, my experiences with the few patients I've done it in, and yeah, I think it really does, because it's not me telling the person with hemophilia, this is how you need to treat. It's really us together figuring out, can I do this? Is this something I want to do? How about this way? We have that back and forth discussion and figure out what's going to work best for you. And I think I find that with my families, that if we're all making the decision together, we tend to have a better uptake. A few examples, I had one of my adolescent patients who was very active. He was on the volleyball team and he also did dance. So he was busy 5 out of 7 days. And really we had this conversation and I said, you know, at this point, I think we almost need to, this was before extended half-life factors. So he was on a standard product. And I said, well, really, I mean, you know, for this 2 to 3 month stretch where you're playing volleyball and really intensive dance, I think you got to treat 5 days a week, because any bleed is really going to totally mess up your dance schedule and you may lose your volleyball season. And so sometimes it's having difficult conversations and really looking at what could go wrong if we don't treat at whichever level we agree on. So sometimes looking at it from what's the worst case scenario can also help with adherence. But I find if it's a mutual decision, I tend to see better adherence than if I'm being more prescriptive.
Looking at it from the transition
Go ahead, Hilary.
perspective, when patients start to understand prophylaxis when they're in their early teens and getting more into activity and becoming a little bit more independent in their decisions, I've really noticed that as I transition to the adult clinic, that the guys that are about 22, 23, there's about 60-40 split where 60% of them have no problem sticking to their prophylactic schedule. They're 100% adherent. We see no bleeds annually with them. And then 40% will kind of fall off and go on demand or try to stretch out their factor to see how long they can, just not treating, say, 3 days a week, maybe treating once a week for a couple years. And then they hit some sort of injury, and then I think they realize how important that prophylaxis treatment and just that having that habit kind of built into their lifestyle so early on is really beneficial moving forward.
So we have some more questions, but let's keep them for the end because we really want to get to Hilary's presentation, which really gets into more of the nuts and bolts of PK testing and how to go about it. So if we can have Hilary's presentation, Hilary Hamilton from the Edmonton Center.
Okay, thank you. I'm just going to wait to see if I can move my slides.
Should be able to take control there, Hilary. I just haven't seen your mouse yet. There you go.
There we go. Okay. All right. Hello, everyone. So yeah, like was introduced in the beginning, I am the bleeding disorder nurse coordinator for the adult program in Edmonton at the Center for Bleeding and Rare Blood Disorders. And in this presentation, on the previous slide, I jumped too fast, but I'll be reviewing personalization and individual tailored prophylaxis from the nursing perspective. So personalized medicine is a type of medical care in which treatment is customized for an individual patient. Individualization is viewed as a modern term and can be applied to any chronic condition in healthcare. As we know, there was a one-size-fits-all approach for quite a long time. Personalized medicine is a movement from the traditional one-size-fits-all approach in which all patients with the same diagnosis would receive the same treatment to a treatment strategy based on the person's unique profile, individual needs, and lifestyle. Some of the treatment goals, oh, sorry, I just got to move my people. Some of the goals of personalized medicine are selection of optimal therapy and reducing trial and error prescribing, allow safer, more optimal dosing options by tailoring dosage to individuals' unique profile, improve patient adherence, enable the patient to tailor treatment based on personal lifestyle, and reduce the overall cost of the healthcare system if we are potential. Sorry, Rebecca. Oh, there we go. Okay. With personalized medicine and the steady advance of modified clotting factors, we would like to see persons with hemophilia experience extremely low bleed rates, almost full prevention of hemophilic arthropathy, fewer restrictions placed on everyday activities, and an overall increased quality of life. So the role of the nurse in personalization is to help provide education to help understand the benefits of pharmacokinetics, otherwise referred to as PK, and explore what a personalized approach to treatment may look like to patients, family members, caregivers, or other healthcare providers. So some of the fundamental points reviewed are: what is factor VIII half-life? What is factor VIII peak and trough levels, and why is this important? Explaining time until 5%, 3%, or 1% of factor VIII levels are reached, and what are the advantages and disadvantages of PK-guided personalization. The nurse at your local hemophilia treatment can also explain the process involved in PK testing. This will include what lab results are needed, the different time points required following your regular factor VIII infusion, and can coordinate any other PK assessments required. Once an individual treatment regime is developed, the nurse will be able to continue monitoring your progress and adherence based on what is documented on paper charting logs or on CPDR treatment entries every time the product is ordered. Okay, so personalized care for hemophilia management, as we previously mentioned, encompasses a unique biological profile and personal needs or lifestyle choices. An individual's unique biological profile includes genetic factors and their pharmacokinetic profile. Personal needs or lifestyle choices can include a patient's individual goals, daily activity levels, and/or their occupation. As outlined in this slide, there are many points to be taken into account of when developing an individualized care plan for hemophilia management, and I know Dr. BELLETRUTTI went over these as well. Age and weight, bleeding frequency or phenotype, the current joint health, is the patient adherent? If they are having issues with adherence, why? Do they have good access to healthcare? Are they able to come to clinic? If not, why? Physical activity and lifestyle, and then what are the patient's goals? If the patient's goals do not match the nurse or the clinic's goals, then issues are likely to arise with the treatment regimen that the patient is on, and of course, pharmacokinetic response. So what is pharmacokinetics? Pharmacokinetics is easiest described as what the body does to the drug, or in this case, factor VIII. Pharmacokinetics is a branch of pharmacology that refers to the movement of the drug in the body. This includes the process of its absorption, or how the product gets into the body, distribution, where the factor goes in the body, metabolism, how the factor is broken down in the body, and excretion or elimination of how the factor is removed from the body. Pharmacokinetics are important in the role of hemophilia A or hemophilia B, as the treatment goal is to maintain factor VIII levels above 1% at minimum. The more time factor VIII levels are below 1%, there is an associated risk for increased breakthrough or spontaneous bleeding. Factor VIII pharmacokinetics can vary significantly among patients, even within the same family. So I love this slide. It's a great visual that I try to use with my patients when I'm going over pharmacokinetics in clinic. And I find it's very simple, but very effective. So imagine that we have two different patients who would be given the same dose and the same amount of factor VIII. This could be patients who are similar in weight or height, or I also like to use the example of their two brothers with a similar weight and height as well, just because the pharmacokinetics can vary completely differently, even within the same family. When we talk about pharmacokinetics of a single factor infusion, it's very important to understand the variability between person to person. Despite both patients infusing the same dose of the same factor, both patients A and B both have very different PK profiles. Patient A is said to have a short half-life since they have eliminated factor VIII faster than patient B. Therefore, patient A may require prophylactic factor VIII infusions, say every 2 days. Since patient B has a longer half-life, their prophylactic treatment regimen may be infusing factor VIII every 3 to 4 days or twice a week. I also like using the analogy sometimes just to give a better visual of 2 different cars too, and just the cars use up the gas a little bit differently. So when developing a personalized PK-guided treatment regimen, individual needs and lifestyles play a significant role in addition to variations in PK profiles. As mentioned before, it is very different to discuss and review the patient's goals and daily activities to ensure the clinic's goals and patient's goals are similar to ensure adherence and success. Patients with different lifestyles may require different factor trough levels. Expert consensus guidelines recommend specific factor trough targets for different patient types. Some patients with moderate hemophilia A still bleed sufficiently to require prophylaxis. Some patients, prophylaxis targeting greater than 1% trough still present with bleeding. Pharmacokinetic response can change throughout one's life. As a child who is very active and unpredictable in activities, treatments may be more frequent to maintain a balanced factor VIII level compared to a more sedentary lifestyle later in life, which Dr. Belletrutti already discussed as well. And then infusions can be adjusted to a lesser frequency if needed. So this is another great visual, again, very similar to what Dr. Belletrutti talked about, but it's a great application of some of the information that we've already reviewed. So the patient's peak level after an factor infusion is about 15 to 30 minutes. It's important to note that if sports or activities are planned for your week as to when you're going to be planning to infuse, as you can see, a higher factor VIII level will be provided better protection from bleeds for sports of, I guess I was going to say higher contact, but not necessarily, skiing, soccer, or basketball, if being played in comparison to a leisurely bike ride or walking, where one may be able to do that activity with a lower factor VIII level before treating again. So here, I just wanted to discuss why personalizing hemophilia treatment with PK-guided prophylaxis is so important. PK-guided dosing is a strategy to address inter-individual differences in pharmacokinetic responses. Personalizing care by targeting trough levels are more beneficial to our patients in providing optimal care. So as you can see on the right, the historical weight-based dosing approach involved not really knowing what vial size you should be using or knowing how often to infuse. As we've moved towards individualized PK guided dosing, the patients are able to use the results for themselves. PK profiling, together with the comprehensive team approach, can be used to help patients engage with their own treatment regimens, improve assessments, and individualize based on their lifestyle. Here are some of the examples of the user-friendly platforms that are available for individual PK profiling for factor VIII and factor IX treatments. Both platforms are specifically designed for the personalization of factor VIII treatment. On the left is called My PK Fit. This platform is used more so for Idanovate or Advate. And on the right is WAPS Hemo, developed in Hamilton, Ontario, and that can be used for any product. Both programs have unique capabilities with the same overall goal of improving hemophilia management. However, It is important to note that not all hemophilia treatment centers are actively using these platforms. So if you haven't seen them before, that might be why. When performing a PK assessment, as Dr. Belletrutti kind of went over as well, usually about 2 to 3 blood draws are needed. So as you can see in example 1, the patient brings their product and infuses their regular factor VIII dose while in clinic. Approximately 3 hours post-infusion, the first blood sample can be taken. 1 to 3 days later, the patient returns to the clinic or hospital laboratory for the second blood sample to be drawn. The second blood sample then provides a 24 to 72 hour factor VIII level. In example 2, factor VIII is administered at home approximately 24 to 72 hours prior to the patient's appointment. The first blood sample is then taken at the beginning of their clinic appointment. The patient then infuses their regular dose of factor VIII with the nurse or whoever else in the clinic. And the second blood sample is taken about 3 hours following the last infusion. So this approach may help save some time for the patient, having 2 blood draws in 1 day instead of spacing it out over 2 days, especially if they're from out of town or don't have easy access to a hospital laboratory. Sometimes a third blood sample may also be taken in the 15 to 30 minute range after the infusion, just to provide the patient's peak level of a factor VIII or 9. And then if you're interested, as we kind of mentioned, in completing this PK assessment, it can be done anytime. I know we kind of went on hiatus over the summer just with COVID, but I had a patient call me today and ask me if he could go get it next week. All right, in this slide, there's just another example of what is actually shown on both platforms. So on the left, you have WAPS Hemo, and on the right is my PK Fit again. With WAPS Hemo, you're able to, oh, of course my Zoom, there's an update going on my computer. Okay, I'm back. With WAPS Hemo, you're able to view your PK curve and see when your levels are at the 5%, 3%, and 1%. And then my PK Fit is capable of providing different scenarios of your prophylactic treatment regimen, and you're clearly able to see your peaks and troughs. And then just maintaining your records on the mobile app. So all hemophilia treatment centers in Canada, with the exception of BC, because I use a program called iChip, use my CBDR to maintain infusion records on a mobile app. There's the odd patients that still submit paper charting logs just because they might live in the country or they're not really tech savvy. But through my CBDR, you're able to easily log treatments, view your treatment plan, and record your bleeds. Your hemophilia treatment team can also access your profile to view your records in real time and are notified when you log any treatments for bleeds. My CBDR is amalgamated with my WAPS, where one can generate their PK curve as well. And the screenshot of my PK Fit shows you also where what you would be able to view through the app. You can see your infusions, bleeds, a reminder of when your next infusion is due, and the factor meter at the top of the screen displaying an estimate of how much factor is left. Both platforms are very user-friendly and great for patients or families. It provides a visual way to further show and educate patients their pharmacokinetic response and the ability to walk through different scenarios or options to help further decide on a treatment regimen suitable for the biological profile and lifestyle. So then we're going to move into my adult case study. So I have a 62-year-old patient, moderate hemophilia A. His baseline was about 2%, and he was diagnosed with hemophilia A as an infant after sustaining an injury in the bathtub. Very extensive family history of hemophilia A, and he weighs about 140 kilograms, and I think I converted that into about 6'1" if you want to take it away from the centimeters. So other comorbidities, he had hepatitis C, but was cleared of that in 2005. He is obese, He has high blood pressure and has bouts of depression kind of every couple of years. In the past, he has had a right elbow radioactive symptomectomy in 2004, and he's had both knees replaced in the last just over 10 years. He has hemophilic arthropathy in all 6 index joints. Target joint is his left elbow. He has no history of factor VIII inhibitor. His bleeding phenotype, history of recurrent bleeds to all 6 index joints. Prior to beginning prophylactic treatment, he just treated on demand and experienced about 20 to 30 bleeds per year. He began weekly prophylactic treatments in the spring of 2019, probably about talking to him about prophylactic treatment since about 2016. A very sedentary lifestyle. He's been advised to lose weight. He works full-time in project management, so office work. He does coach baseball during the summer months, but not too much activity otherwise, and just all that throwing usually irritates his left elbow, and he can go hunting in the fall sometimes. So in 2018, he was really having a hard time differentiating between joint bleeds and pain from chronic hemophilic arthropathy. He didn't really feel that his factor VIII replacement was helpful when treating with 1 or 2 treatments for acute bleeding. I know we looked into if he had an inhibitor or not, played around with the frequency and the dosing of the standard half-life product at the time just to see if that would have helped, but it still really wasn't working for him. So there was a lot of discussion. Like I said, it was about a 2-year process for him, just really taking away some different points and thinking about it, but just really what was optimal infusion frequency for him. So the trial of weekly prophylaxis therapy, or at the time, the upcoming research trial for 2 years, adherence to the prescribed factor VIII replacement therapy. So him just really getting into the habit of even 1 day a week at the beginning was a bit overwhelming for him, and just exploring other methods of pain control. So I just wanted to go over this, and this was what I had mentioned. His elbow, he had a radioactive symptomectomy done. So that's the x-ray of that, and then just the 2 knee replacements. So while we looked at individualizing his care again, just possibly modifying his treatment frequency or day of administration, and really worked with him on that a lot, to optimize therapy adherence through education, and then trial of Celebrex for hemophilic arthropathy, and just the normal the rest ice compression and elevation to help him when he did have pain or a bleed. And the plan, as I mentioned, just the trial of weekly factor VIII prophylaxis to have the patient slowly begin to develop a habit of treating preventatively. This took him about 3 to 4 months to really just get into and start to see the benefit of. And then the treatment goal, we wanted him on twice weekly prophylaxis. That would have been his optimal therapy to maintain higher factor VIII trough levels to offer him better protection from recurrent joint bleeds, given his high bleeding rate and hemophilic arthropathy involving all 6 index joints and recurrent left elbow bleeds. So as of right now, he just, with his work schedule and still kind of having on demand in the back of his head, I think, as this wasn't something he grew up with, he just remains on weekly therapy. He's been on that for just about 2 years now. He's not interested in increasing his infusion frequency since his annual bleed rate has dramatically decreased. So that's great. And then evaluation after 6 months, when he did start this treatment regime, he denied any chronic pain on a day-to-day basis, and he's just not interested in any further PK testing for the current product that he's on, as he's had it done previously in the past. And I'll bring up this conversation, I plan to, if we switch products for him in the future. And that's it.
Okay, thanks a lot, Hilary. A couple of quick questions for you.
Yeah.
From our audience. How do people access the apps. I guess they should know where my CBDR is, but perhaps not. And especially the my WOPs or the my PK Fit apps.
I can actually probably only speak to my CBDR. I know our physician uses WOPs, but we haven't shared it with the my WOPs with the patients yet. But for my CBDR, you can go to mycbdr.ca if you want to register to sign up, and this will replace your paper charting logs. All you have to do is really easy. On the main screen, I believe it says new user. You click that, fill in your demographics. That will, once you press OK, an email will be sent to your hemophilia treatment team, either the nurse or the data entry clerk. They will approve it, just review what your current treatment plan is in. Once it's approved, you'll get an email saying you're good to go. And then just there is a help desk to help you for a CBDR, or you can call your hemophilia nurse or data clerk, and they can walk you through how to actually enter the product and enter your treatments. And it's awesome, and it's easy, and everyone can view it.
And maybe I'll just add that having used the MyWOPS app, it's fantastic because it's linked to my CBDR. So you just have to enter your infusion once in my CBDR, and it will transmit that information to MyWOPS, and you get the readout of your factor levels on MyWOPS. You don't have to enter the information twice, which is great. One last question for Hilary before we move on to Cleveland. One person asked, how do I know if I'm a good candidate for personalization? Does this work for everyone? Maybe this question both to Mark and Hilary.
It's something that's for everyone. Anytime you can personalize a treatment, I think it's providing the optimal care for you. As we kind of discussed in that example with pharmacokinetics and the way different people use different factor. Even I use that example and I threw it in there because we do have two brothers. They're 2 years apart. They're very similar height and weight, but they completely metabolize factor very, very differently. And their bleeding phenotype is different. The bleed severity is different. And so if we had them on the traditional one-fits-all weight-based dosing, they wouldn't be receiving adequate treatment. Like Dr. Belletrutti had mentioned too, we're there as a team. We want to see a zero bleed rate. And so to us, that means personalization. So whatever we can do to work with you, work with your lifestyle, your motivation factor, do we need to help a little bit in that area? Then all of that is encompassed, I think, in personalization. And I think it's a really, really good thing.
A quick question for Dr. Belletrutti. Will my PK be the same for all products?
No, it can be different between products. So certainly it'll be very different if you're on a standard half-life product and you switch to an extended half-life, then we will see differences. But there can be differences as well among the groups of products, whether it's different extended half-life products or different standard half-life products. So yes, you will have a different PK, and you know, that's one of the times in conversation where if I switch a patient, I'm interested, and I try to help the patient be interested as well in seeing how their PK has changed with switching to a new product. And I usually encourage to try and get that information at least a few months after they've started the new product. David, can I say something quick about my WOPs?
Go ahead.
Yeah, it's fairly easy to sign up. You do have to contact your physician, and they will help make sure that you've at least done a PK. But if you have a PK, then your physician or your team is able to help activate an account for you, and then you can register and download the app. And it's freely available on both the App Store and Google.
And I know a bunch of people who use it, and they just love showing off what their level is at any given moment. And they also come to conclusions about when they're safe or when they're not safe, when they're protected or not protected, because they know at every moment what their level is, and they can correlate that with when they have bleeds. Okay, let's move on to the patient perspective. We have Cleveland Pagani here from Edmonton. Perhaps just, could you introduce yourself a little, Cleveland?
Sure. My name's Cleveland Pagani. I have severe hemophilia A. I've been on prophylaxis for about the last 20 years or so. And I guess I'll take any questions.
All right. So I think you did consult for some personalization. Did you have a particular goal in mind in your life that led you to ask questions to your physician about perhaps personalization of care?
Yeah, great question. So even though I've been on prophylaxis, I still had breakthrough bleeds, sometimes for trauma or periods of activity, or sometimes just spontaneous bleeds. So I wanted to have more protection from bleeding, and I also wanted to treat less, if possible, just because it's not fun having injections all the time.
And did those bleeds have an impact on your life? You know, by reducing them, were you hoping to make some changes in terms of your real life outcomes?
Yes. Sorry, what exactly was the question?
Well, in terms of did those bleeds keep you from doing things that you wanted to do? Did they make your life difficult in some ways, and you wanted to make some changes?
Absolutely. I have a few target joints, and yes, I like to be active, doing biking in the summer and skating and things in the winter, and having bleeds definitely would set me back from doing those things.
And you have kids too, don't you? So there's
yes, and they're very active as well. So it's nice to be able to stay active and not be laid up with an ankle bleed or anything else.
So could you tell us the story of consulting your physician? What process you went through and what changes you made?
Absolutely. So a couple of years ago, I switched from a standard half-life product to an extended half-life. And as a result of that change, I was encouraged to do the pharmacokinetics study. And as was just being discussed, now thinking back at it, I wish I had done the PK before I switched, because I only did it after. And so I don't know what my levels were at before, but as a result of that switch of products, I wanted to do the PK study. And the process was pretty easy. Went into the clinic and I did the second option that Hilary was presenting on, where you get a blood test before your clinic appointment and then infuse and then come back and get a few subsequent blood tests. And as a result, I learned that so I was typically treating in the evenings when I was free and available and having time for that. And I learned after going through the PK process that I was sleeping through the most protective time that I had in terms of my factor levels. And I never really considered that before or talked about it. And it wasn't something that was ever asked or discussed in any of my clinic visits before. So again, because I like to be active, it didn't make sense for me at all to be injecting and then going to sleep right away for the next few hours, right? So I changed my my prophylaxis routine to treat in the mornings, which I think has made a difference in my bleeding. Additionally to that, I was treating every 2 days, sometimes every 3 days on prophylaxis, and I was able to switch to doing every 3 days, unless I'm doing heavy activity, in which case I, as was discussed, have some flexibility to do treatments more often when I know I'm going to be really active. In the summer, if I'm going to decide to do a bunch of hiking or something, then I will treat more often to have better protection.
Did that PK trial tell you what your trough level was at the end of, say, at the end of those 3 days?
Yeah, I can't remember what it was now because it was a few years ago, but it was somewhere in that 1 to 5% range. I'm switched products again, and I'm going in for another PK test, so I'll have that fresh information coming up soon. But it was discussed, and I guess as far as the personalization, I had a discussion with my physician to just say what level are you comfortable with for your trough level, and I was comfortable somewhere getting to a low point of somewhere within that 1 to 5% range, and that's how we went with going with every 3 days.
So did you reach your goals? Did you sit down afterwards, say a few months later, with your clinic team and discuss how things had gone?
No, that's a great question. I should do that, and it wasn't. I never followed up on it. I think that's just because I was having success with it, so it wasn't something that was discussed again. But it probably should be. So.
But as far as you're concerned, you were meeting your goals.
Yeah, I was able to have more protection because of the switching to infusing in the morning versus the evenings, and that's what I wanted to do, was have that greater level of protection. And again, I was able to go. I was sometimes infusing every 3 days anyway, but I had better peace of mind, let's say, because I knew that I wasn't dropping to the 0 level.
Would a tool like MyWOPS, which gives you a readout of your exact level at any time of the day or night, would that be a useful tool for you?
Absolutely. I'm very interested in this. I'd like to give it a try. And I actually have a question, maybe that I can, I don't know if I can ask it now.
Absolutely,
but
go ahead.
yeah. My question is, can you use WOPS even if your clinic isn't registered? Because I think I tried to use it before, and I wasn't able to get in there and use it.
Question to Dr. BELLETRUTTI.
I think you just have to discuss with your own physician, and I mean, if you have your PK in the WOPS system, then they just have to grant you access to it. I mean, my WOPS is fairly new, so it's not something that was available even last year.
Okay.
So I'm still learning how to do it as well. But from what I can tell, we, it allows us to have the conversation, and we would give you access so that you can register and look at your numbers.
Yeah, the hard part for your clinic is the PK trial, and for you, the easy part is putting that information into MyWOPS. That's pretty simple.
Great.
Okay.
I'm looking forward to it.
Any last comments about personalization, Cleveland?
No, I want to say that I'm happy that I did it, and that I went through and did the PK testing. It wasn't that huge of a time commitment, and I mean, we're going to get blood all the time anyway. So I would suggest, if you're interested in it, schedule it with your clinic visit, and the process at the clinic, they were really good about providing a space for me to treat while I was there. And I know the lab here in Edmonton was able to prioritize my blood test because of the time sensitive nature of some of the results at the very beginning anyway. And so the process was really good, and I would recommend that if you're interested, go get it done.
Great, so let's move to the general question and answer period. And so these questions will be for all of the speakers. So here's a tricky one. Are most treating physicians comfortable in initiating this kind of approach? And by this approach, we're talking about personalization and the shared decision-making that Dr. BELLETRUTTI was talking about. So Dr. BELLETRUTTI, are your colleagues comfortable with this kind of approach?
I would say by and large, yes. It's interesting. I'd say definitely I can speak as a pediatric treater in the pediatric age group, where family-centered care is what we do every day. So we're used to this collaborative back and forth with the parents and the child when they're old enough to participate. It's an evolving area, and I think a lot of us across Canada for sure are getting very comfortable with this type of approach, and having the technology that allows us to interpret it and share it with our patients in a reasonable manner also is increasing our comfort. So short answer is yes.
And here's another interesting question. Does personalized therapy allow for all physical activities?
So I will say that what I call collision sports are still a no-go. So what is a collision sport? There's two definitions. One is that any reasonable person, whether they have hemophilia or not, could get seriously injured and bleed because of the type of sport they do. I think those are just, we really have to discourage participation in those types of sports. So those are things like, I don't think being an MMA fighter is a wise choice. High level football where you're deliberately running into someone, I think, maybe we can find something else. There's great debate. I mean, we're a hockey country. Should we allow you to play hockey when you're able to check? Because now you've gone from a contact sport where when there's no checking to a collision sport where you're trying to run the person over. So, I mean, those are harder conversations because really we have to acknowledge that, even if I get your factor levels up to 100%, I cannot guarantee that you're not going to bleed just because of the type of sport it is. So, and
you're not going to be always at 100%. You're going to be sometimes closer to your trough level of 3 or 4%.
Exactly.
And then you're certainly not protected against those kinds of injuries.
Correct.
And another question, probably to all three of you, from all three perspectives, what are some of the challenges that are preventing PK testing?
Right now, it's COVID. I think that impacts a lot of things. From my perspective, it's something that people haven't grown up with. And so it's breaking the mold, breaking old habits, and educating. Like I mentioned in my case study, it can take a couple of years for people to get on board, but it's finding different methods, the visual, the written, the apps, just to get them to understand why we're doing it and how much benefit there is to providing the results. Yeah, that's from my perspective.
Are there perspectives on the challenges or the barriers?
I would echo that and say that, I mean, this is a complex topic. We've spent an hour trying to explain it. And so being able to distill that into a clinic visit where we're explaining why we think this is a good idea, why I think you need to get, 2 or 3 different blood draws all in the span of a day, I have to be able to convince you that that's a good idea. And, this is a complex topic and sometimes it takes time.
Cleveland, from your point of view, from the patient perspective?
Yeah, from the patient perspective, the biggest challenge for me was just setting aside some time to go in for those multiple blood draws. And at the end of the day, it's not really that much time, but it depending on your work schedule or your school schedule or whatever you've got going on, that could be a challenge. So it's just taking some time off or scheduling it however you can.
And how young, Dr. Belletrutti, would you do this? I mean, you mentioned that it's more difficult in very young children who, with difficult venous access. But would you still encourage younger children to have a PK test?
I think, yeah, if the situation asks for it, if they're quite highly active in certain activities, I'd like to know where they're at. Some of my patients have the benefit of having a central line, so drawing blood is actually easy, because we have to access them to give factor anyway, and so we can draw blood out of the same needle. So that sometimes helps us in the younger kids where we really think it's beneficial. But yeah, it's very situation dependent, but yes, it can be done at any age.
Well, I think that's the end of our questions. For those who are attending today, this session has been recorded, and Medjucom will be posting it. We'll be sending it, I think, to CHS, and we'll be posting it on our YouTube channel. So for those who didn't have a chance to watch during supper, you can come back to it and view the whole presentation at a later date. Any last comments from our presenters?
David, if I may, I have one more question. I wasn't allowed to type questions in here myself, so
Okay.
I'm wondering how often PK testing should be repeated, and do we have any data on repeat testing on the same individual?
I didn't want to, oh, go ahead.
Go ahead.
I didn't want to dive into it, and I don't know the source of it, but in researching for this presentation, it did, yeah, I can't remember where I saw it, but trough levels can increase as you age, especially over the age of 40. And I don't know if Dr. BELLETRUTTI, if you've seen that anywhere. So I think, I mean, doing PK on different products is kind of a no-brainer just to see where you're at for that. But I don't know, I'd say every 10, 15 years, your body goes through a lot of changes, and I think it'd be a good idea to see where you're at if you've been on a product for that long.
Yeah, I would agree with that. We would have to do more frequent testing in childhood, because a 4-year-old will metabolize factor VIII differently than a 10-year-old, who will do it differently than an adolescent. And then as they get into young adulthood, there could be changes as well. So those are time points where we may want to look at that if they're on the same product. It's different now that there's so many different products available. So as was mentioned, switching products is a good time to see, how do you handle this product? How differently do you handle it compared to your previous product? Because usually there's a good reason why we're switching, because we want to do better than our previous product. So it's nice to justify that with the numbers, in my opinion.
And then I suppose if your life goals are changing, if something in your life is changing, you may want to see what a PK trial can give you in those terms. You know, perhaps either becoming more active or becoming less active, or moving away from home, or many different situations.
Yes.
Great. Well, it's been a fantastic presentation and evening. One last round of thanks to our 3 presenters, and I wish all the attendees a great evening.